Okay. Hi. Yeah, we're back. So it's time for questions. I'm looking. We had quite a few people watching, but I don't see any questions yet. Anybody?
It's okay. It's all right. We can just talk about it ourselves, though. Oh, it's Jack.
No. So, yeah, that's Jack. He likes to help. What did you think, Jack? So one, I really love your talk, and there's just so much where I think we don't consider how much we impact what we're doing, and what an impression we make by that person that we might have seen 10 times or that one person we saw that one time. So I really loved just bringing all of this up. And also, Rajan reminded me there's going to be a little lag, so hopefully we'll be getting some more questions here shortly.
Right. We can fill it in. We can fill it in.
Just keep filling. I love it. So have you always been like this, or did something happen that made you go, things could or should be different?
You know, I would say that it is a pretty common feature of my life that I am the person that asks the question that is annoying or asks why when no one wants to consider why, or, you know, things like that. So it's kind of nice in adulthood to be able to go down those rabbit holes myself, and not have anyone be annoyed that I'm asking, because I can answer it myself. I can investigate on my own. And I think this is something that we just aren't taught, right? We're not taught, so we don't know. We know it exists. Yes, that sounds nice. But I think the fact that as healthcare practitioners, we are inextricably linked to the individual's pain experience is something that we really need to hold with care. I think it's easy to assume that there's this very transactional kind of approach. And, you know, we can't see inside the person's head, but there's enough evidence for us to know that we need to pay attention, you know, to how these interactions play out. And when you look at how predictive of outcomes some of these elements are, it raises the question, if I treat shame, if I treat the identity, if I, make those my targets, I think we could call that treating pain, right? Looking at helping them feel like they are still part of their group, that they are able to participate, because then they feel like they're still in good standing within their group. And it kind of helped validate, I think, a lot of what I know, how I practice, how you practice, how lots of other people practice, that other people might think of as, well, is that really being a physio, or, and I think it is. And I think this kind of helps bolster that.
I agree.
Yeah,
that was so well said.
I knew you would agree. I knew.
And now we do have some questions from the participants. So here comes the first one of, how do you think the healthcare system is supposed to change?
I think we need to start before the healthcare system, right? I think some of these are cultural expectations and educational expectations. How are these things taught in school? I kind of pointed out that there's this emphasis on, addiction prevention instead of pain management. I think that, at least for the PT students that I get, while they are taught the biopsychosocial model, they don't really know how to apply it. And they certainly don't understand how they factor into the equation. Changing a system is hard. Obviously, requiring a diagnostic code and as a gatekeeper to care is exceptionally problematic. But I think it starts with more awareness amongst healthcare practitioners, and I think that comes with a very big push towards better pain education and how robust and full that really needs to be in school. Something that I picked up on in my reading was that a lot of times some of these dynamics are modeled for students by seasoned professionals, right? And how we talk about patients. Oh, this is a difficult patient. Or, patients that are able to give us what feels like more concrete, objective information somehow feels like a good patient, and kind of working on that comfort with discomfort and not appraising the value of the individual based upon your comfort with what's happening. And, obviously there needs to be a radical shift. I think there's a lot of us that model this, right? I think that I model it for my colleagues. I model it for my mentees. I model it for my students. I certainly model it with my patients, right? So they know that there can be another way. Does that answer your question?
Awesome.
Maybe.
I don't know if they're going to let us know, but I think so. I think that was another great answer, Devra.
Thank you.
Okay, I'm going to do this one next. There's a couple more words that didn't fit on the slide. So the presentation brought to mind the current conflict in the culture between wearers of masks and observers of extreme social distance versus others, the challenge of power and challenge of community, and other ideas in that vein.
So this is
I don't know if you have
statement, not a question, right?
More of a statement, not a question.
Okay. Well, it sounds to me like there are people who, part of your, I guess, identity is that you're in a group who believes and values, mask wearing versus being in a group who believes and values not mask wearing. And I am definitely not an expert in social behavior, but, based upon kind of everything I've learned, it's about wanting to feel included in your group, right? That is, our social standing is really important. It is it helps us know that we will survive because we are supported and that we are firmly within our group, right? We are not outliers. We are not at risk for excommunication, right? So I think to some degree it becomes about group identity. Does that, I see it everywhere. I can tell you that I see these themes all over the place. So there's not much you can bring up to me that'll be like, yeah, no, I don't think that applies. I think it's everywhere.
I love it. And you've really inspired a lot of comments, and we're going to get to a question. But this one I just wanted to share with you. Wow, thank you. No question, but just can't wait to listen to this several times.
You're very welcome.
Okay, so here is a question. How do you think we can start to restore equity to marginalized populations in healthcare?
Well, so I've been a clinician for 16 plus-ish years now, and about 14 of them have been working with low-income populations. So I think there's a whole lot that we need to consider and do. I think that we have and I can only speak to my knowledge of healthcare systems in the United States, but there's massive amounts of inequity in terms of access, right? Hospitals and practices that accept Medicare, for example, are not required to accept Medicaid. So that is our kind of low income and state insurance. And while I understand, smaller practices, it's far less feasible. We're talking about massive systems, massive health systems that severely limit how many patients with Medicaid that they'll see. And when I say massive health systems, I mean hospitals with huge networks, right? I'm not talking about the small guy. I'm talking about the huge guy who's taking lots of government dollars, are not required to see these individuals. And while they technically can't deny them care, they come up with all these little rules that limit access. And I see it over and over and over again with my patients. There's even rules about, so let's say, and I'm going to dig on orthopods, I'm so sorry, but they, to make some extra cash, you'll pick up call in an emergency department. Right? So you take the overnight shift, an emergency comes in, somebody needs surgery, you do it. Because maybe it's a smaller hospital that doesn't necessarily have a large enough ortho staff to cover that and so you can pick up call. Private ortho groups can pick up calls. And let's say a person has surgery, that person only has 30 days to follow up with that physician. So they have a problem 6 months later, there is nothing they can do. They are not obligated to follow that person. So there are so many access related issues. While transportation is technically covered, it's horrendous. It's so bad. And, it would be easier to give people, like PACE, versus some of these transportation companies and things like that. We also, in addition to access, you look at, how many hospitals are clustered together. And in Chicago, over the last couple of years, we've had several hospitals close, and they closed in areas that really needed them. So, I think access is step one, and I think educating about how different populations have different health needs is also really important. And I think sometimes some education touches on it, sometimes well, sometimes not well, but really it's not enough. It's not clear enough. It's not respectful enough. There's certainly huge pushes for more diversity amongst healthcare practitioners. When you look at appraisals of pain, for example, or you look at, I was talking about evolutionarily speaking, that we have our group, right? So we are biologically and evolutionarily more inclined to understand someone within our group. So having a Black physician treat a Black patient is different, right? In a way that I can never know, right? And having more practitioners who look like their patients is really, really important. I could go on and on and on about this. It sounds like Sarah and I have a plan for that in the future.
Definitely. So I've actually been part of some conversations on physical therapy in particular, but how we're not a very diverse profession.
Yeah.
And then really like taking it back a couple of steps to see why. And it goes back to like the systemic issues of, just even having access to the courses in high school or even elementary school that would put you more likely to be able to go to college, period, let alone take the classes that would be necessary to be the prerequisites. And then also, like socially and financially, becoming a PT costs a couple dollars, and
more than a couple. Yeah.
But so just it's a much bigger problem. But I think I agree again that if we can get more people who are diverse to work with those populations who look like them, why would you listen to me? So I think that's a more awesome points. And here's another statement.
Okay.
So what a paradox, a marginalized individual being offered less care that might be consistent with guideline care, perceives an injustice leading to dissatisfaction and reinforcing the victim role.
So I think there was definitely like two studies that I was talking about. In the study that talked about what looked like more consistent care for Black patients versus more variable care for white patients, they didn't touch on the these were not real patients, they were vignettes. So they didn't specifically go into how that care was perceived. But there's definitely other evidence about, less distress, lower pain appraisals, things like that. And my personal experience of 14 years working with marginalized groups, they often don't even recognize the injustice because it has sadly been so normalized. It's what they're expecting. So it is not uncommon for me to hear a patient recount an interaction, and inside I'm having like silent rage about it. And I kind of just hold space for them because they're telling me something important to them. And it's fairly common that it's just, because I'll say, oh, well, did you ask about this? Or, what happened? Just sort of getting more information. And they're like, I don't know, it is what it is, right? Like they've been gaslit for so long, they think it's normal when it's not. But, yes to all the things. I mean, there's so many spokes and like going off in so many tangents we can do with this topic. There's a lot.
Yeah, so much.
Yeah.
And now we have a question from Eddie. How can you foster the therapeutic alliance without falling into the trap of being part of their us instead of them?
Being part of their us instead of them. I work very hard at this in the sense that I reinforce many times over during our sessions that they're the important one here, right? It's not about me. It's what do you think? It's right. People are so accustomed to, going to practitioner to, get care, to get their advice for, whatever, but it is an active process to help somebody continue to feel that they are important and they are listened to. And it's not just like I did this one thing once. It is every interaction, the entire session. It is how I document even, right? If you were to even just read my documentation, you would see significant deference given to them over me. And I think it needs to kind of become the whole thing. And it just becomes who you are as a clinician, I think. And it takes practice, right? It's not like this just happened overnight, right? Because it's so different, I think, than how we're taught, right? We're taught that we're movement experts, right? We're body experts, right? The whole medical model is predicated on my expertise over theirs, right?
So that then I don't see another question on the list, so I get to ask one.
Oh, great.
So what do you think needs to happen in the training of healthcare professionals to perhaps shift the needle a little sooner?
Yeah, I think that, there's so much we could do. Obviously, I think we need to be learning different things, but nobody, when you look at how things are taught in medical school and physio school, and, we have everything is compartmentalized, right? You learn about orthopedics, you learn about neurology, you learn about, physicians are going to learn about endocrinology, emergency medicine, right? And nobody wants to give up any of their time or content, right? And nobody wants to make school longer. And nobody, one of my issues that I've said about pain education is that it is like this add-on as opposed to themes carried out in every class, right? That there is consistent language, that there's consistent messaging, because if we're going to continue with pain is complex, it is emergent, it is this, then we need to carry that thought forward when we're learning orthopedics. And it just doesn't happen that way. So I think that instead of looking at it as this burden of something we need to teach specifically, I think we need to relook at how we're teaching all the things anyway, and how can I modify that content so these themes continue to push forward. Is that?
Just trying to.
Yeah.
Oh,
sorry.
No, keep going.
Something else that came up that I didn't talk about, but I do see it with like physio students, and I can't speak to what medical students go through, but there's a lot more push to reflect on your interactions and your practice. And I definitely see physio students needing to, I have to log in and post my reflection and stuff like that. And I think those are really important opportunities that I certainly took for granted when I was a student. And, had I known these things, if it was, I want you to reflect on how you think that interaction could have maybe been better, right? What could have been different, and kind of like more specific prompts, knowing what we know about shame. I have a patient right now who, when I was reading the article on injustice, they were just like headlights in my mind. It is a huge theme for this individual, huge. And just knowing that even though I have huge empathy for this individual, it just created this other level of understanding for me. And even just being able to say to them, that sounds really unjust. That's not fair. For them to be able to hear a healthcare practitioner say those words, right, and recognize it, I think is really, I hope is very validating, right? I think we have this idea of being professional and not allowed to say something negative about another practitioner. But I think we forget that sometimes it's those interactions that can be really traumatic. And I don't need to validate that. My job is for the person in front of me to feel supported. And I'm okay with saying that was awful. That should have never happened. I'm really sorry that happened, and kind of teaching people and empowering them. And I think that there's a lot between like student and instructor dynamics, especially medical students who are following attendings and watching those interactions, right? And they never kind of not decompress, but kind of like review and say, it's held as this is what you're supposed to do, and you need to get with the program, as opposed to reflecting and saying, maybe this isn't how I want to practice. Maybe I can do it different. And I think kind of using those reflective opportunities more, I think, is a really important thing for us to engage with.
Yeah, I actually really appreciate what you said there about, right, so you go to and you watch your attendings, you watch your clinical instructors, and this is how it's supposed to be done. And again, going back to the school idea of maybe we can do better empowering the students, future healthcare professionals, to go, okay, not how maybe I want to do this, or maybe not the best way to go about it. And I think that might be a little piece that I would like to do for students, is to kind of give them that, I don't know, permission, idea, empowerment. I don't know that it would have occurred to me as a student to question like that.
I question everything all the time, so no.
I do now, and it's like you said, now that you're an adult, you can just figure it out on your own, and you don't annoy people. I'm like, oh, I annoy people on the regular with my questions. Okay, so we don't have any other questions right now. Do you want to leave the large group with any final thoughts before we scooch over to the discussion?
I mean, I could talk about this topic all day. So I'm around if you want to chat later, if you have thoughts later, if you're noticing that you're simmering about things and you're just like, I really need to express this thought, or when I was going through this content, it was always like, oh yeah, and then this and this. And it's like literally the lens I see everything in. So I am here. Find me. You can email me if you don't see me on the platform, and we can talk about all the things.
Awesome. All right. Well, thank you so much. It was a wonderful talk.